All right. So, my name is Cassandra Baker. I am going to be talking about Loud in the ED in Fort St. John. I do want to quickly acknowledge that I'm joining from the ancestral and traditional territory of the Treaty 8 First Nations, otherwise colonially known as Fort St. John. And this is a beautiful picture of the Beaten River taken near the Doig River First Nation, which is quite close to Fort St. John. So my background is I have my emergency specialty. I also work in the ICU on occasion, and I have my certified practice in opioid use disorder. I have my current role, and my role from Monday to Friday is the substance use resource nurse, and it is a regional position. So I do cover Fort St. John, Fort Nelson, and Hudson Hope. But I did have to focus this pilot project on Fort St. John specifically. One second. So just a bit of a background on Fort St. John Emergency. We serve 6 communities, so we're a regional hospital. So it's Chetwynd, Tumbler Ridge, Dawson Creek, Hudson Hope, Fort Nelson, and Fort St. John, as well as various other outlying communities and many First Nation communities within the Treaty 8 territory. We have approximately 17 rooms to work out of in our emergency department, and we have 1 physician on at a time. And generally 1 triage nurse, 2 floor RNs, and 1 floor LPN most days. We also have a fairly robust multidisciplinary team now, which is quite exciting. So our objective with Loud in the ED, which is learning about opioid use disorder in the emergency department, it is a provincial initiative to improve quality of ED care for people living with opioid use disorder. And this was done in partnership with Health Quality BC. It's to strengthen OUD care in EDs, and it's critical to saving lives and reducing opioid-related harms and reducing the burden of the toxic drug poisoning public health emergency. By participating in Loud in the ED, teams can accelerate provincial change in improving OUD care, and by accessing practical tools, resources, and clinical and quality improvement supports. For Fort St. John specifically, our objectives had a rural focus, considering resources available to us, existing processes, and barriers identified within our team. We also wanted to clarify existing processes, implement new processes where they didn't already exist, and reduce stigma. We also wanted to improve communication with community and ultimately improve care. So there were a variety of methods used to and implemented with the aim of improving care for patients with OUD in the ED. And this included action period calls. These were monthly virtual calls where accomplishments and lessons learned were shared across teams in the province. So as this was a provincial initiative, there were teams in different emergency departments across the province, and we got to share our wins and barriers and problem solve together, which was really cool. There were learning sessions. There was one really phenomenal in-person learning session in April, and it was great to be able to at least meet the teams once in person. We all know the value of being able to see each other in person. And then there were virtual sessions monthly. These involved presentations from speakers as well as group discussions with the other provincial teams. We were also fortunate to have a QI coach from Health Quality BC visit Fort St. John. So it was a unique opportunity for her to get a lay of the land of our specific department and how everything worked there, and to provide in-the-moment feedback and speak with our frontline staff. There was also a Teams channel created for this, and we were able to submit our monthly reports through this Teams channel. We shared resources with other teams and had resources shared with us, and we were able to ask questions through this format. This is just a quick snapshot of the driver diagram that was used in our change package to help us guide the change ideas and PDSAs we were using through this quality improvement initiative. There were primary drivers, secondary drivers, and tertiary drivers, which aren't seen on this slide. This is just the front page of the change package. It was developed as a part of a working group that occurred 6 months prior to the actual pilot projects, and I was grateful to be a part of that as well. So it was really cool to see it all the way through. And it included so many different resources and links within there, and being able to connect with the QI coaches to help guide us through using all those resources was really invaluable, and especially the measurement guide, because if you're new to QI like I was, it was a very steep learning curve, and measurement itself was really intimidating. This was our timeline. So it seemed like a really long timeline to begin with, but we are at the very end here at November 12th. That will be our last call, and it's kind of hard to believe now, but it's already coming to an end, and we're bittersweet about it. So change ideas. We had things that worked and things that didn't. So we had created a centralized location for harm reduction supplies with pre-made kits. So staff now are very aware of where they are and how to access them, which is really great, because before, people didn't even know that we had access to that in our emergency department. And then myself spending more time physically in the emergency department. So lots more staff engaging with me, asking questions, and for support. We created a SharePoint site. So this is a one-stop shop site that's tailored to our emergency department specifically, to have links, resources, regularly accessed documents, that kind of thing, to try to make it actually usable for our staff. We had lanyard cards for substance use screening and assessing cows in CEWA, which is withdrawal of opioids and alcohol. And the digital file of the lanyard cards was shared from the Vernon team, which was just phenomenal, because they did such a good job, and it would have taken so much longer for us to create it from scratch. We had pre-made alcohol and opioid withdrawal order set packages. So instead of finding all the papers individually, we put them all in one place and put them together so people could just grab them, and staff were really happy about that. We also did an in situ opioid poisoning sim. It did not go according to plan, although I'm not sure how many in situ simulations do, but we learned a lot about what the staff are looking for from us, so that was really a value add. So this is the lanyard card, front and back. It looks almost identical to what Vernon had done. It just has Northern Health colors and a little courtesy of Dr. Lisa, Dr. Leslie, and Tracy Svetting on the bottom, just to give some credit where it's due. This is our alcohol withdrawal package, which is now orderable through Document Source, so I don't have to physically put them together anymore, which I will admit was a bit of a selfish thing on my part. And then this is the opioid withdrawal version as well. This is a quick screenshot of the SharePoint site that we put together. So it's always going to be in flux, and we'll be working on it, but it's just to try and put things that staff are always using in one place. And this is just lower down on the screen. Obviously, these can be expanded, and there's more information underneath them. So what didn't necessarily work? Staff are still not handing out very much for harm reduction supplies, despite knowing where they are. So this is something we're still problem solving and working on. We're trying to figure out how to gather good data on how often staff are using lanyard cards to screen. And that's a bit of the measuring piece that we're figuring out. Staff are not comfortable with the idea of screening during triage. They're more so comfortable with bedside. And bridging gaps and repairing relationships between different acute and community teams will take some time. So this communication piece, which I thought would be a little bit easier, not as easy as I quite thought. And it took a long time to create and receive the order of oat tearaway pads, which were essentially just like a big business card, which I can show you here. So we just received them this week. So we'll see how I think it will turn out well. I think they will be useful, but I expected these to be available and utilized like 2 months ago. So it goes. Results. We learned how to identify different things to measure. This sounds really simple and kind of silly, but if you're new to QI like I was, you have to really think differently about it. And that was a really big learning step. Some change ideas implemented have been institutionalized, so they will be available as people move on from their positions. We've learned a lot about how PDSAs work, and we've learned to choose a smaller change idea on a smaller audience. So one thing on one person, one thing on one patient, and building up from there. Snapshot of data. It just shows that at one point here, you can see a sharp increase in substance use chief complaint of patients coming to our emergency department, leaving without being seen compared to all emergency department patients. We still haven't figured out why. But the silver lining is we wouldn't even know this if we weren't doing this QI project. So we can still try and figure it out, which I guess is one good thing. Advice for getting started. All right, so if you can get on with like somebody like HQBC, really recommend it, especially if you're new to QI. It's really phenomenal support, leadership, coaching. Identify an area of care lacking in best practice guidelines or clear support or direction. Staff will likely be less comfortable with this work and will have more education or asks regarding practice in this area of care. And try to engage with your QI team local or through the health authority. Connect with the data and information team as early as you can to clarify what your asks are and to connect them with any external organizations you're working with. Network with like-minded colleagues, but cast a wide net because you might be surprised about who actually has really valuable insights. So what's next for us? We are working with CRISM, which is Canadian Research Initiative in Science Matters, to work on a best practice checklist for Canadian EDs for people who use opioids. It is builds on lessons learned and resources created for LOUD in the ED, and it will allow us to continue beyond November 2025 when the LOUD work ends. And it also provides additional funding. So we're really excited about that. We'll take what we learned from LOUD and we will continue the work forward. And this is just a QR code if you're interested in learning anything related to HQBC and substance use. And I'm happy to take any questions.
Thank you so much. That was fantastic. Thanks, Cassandra.
Thank you.
Okay. So I see we have a few things in the chat. Sherry is saying in Northern Health, you can reach out to the quality team at quality@northernhealth.ca. And Sherry is saying that she's in Fort St. John and she loves that if this happened, she loves that this happened here. And then we have Sherry again saying that this is a fantastic project. Great presentation. Any questions for Cassandra? Wow. Okay, well, that was a great presentation, Cassandra, and you got your contacts there, so people can always follow up with you later at a later stage. Okay, so then I would say if there are no more questions, we can start a little bit early with the next presentation. And so I would invite Mary Hannah and Rachel Wells to please go ahead and share your screen with our next presentation.
Thank you, Vivian. Everyone can see the screen fine? Okay. Howdy, everybody. My name is Mary Hannah. I am with the Addictions Recovery Program, the manager here, and I have also Rachel Wells, who's the director of the Quality and Innovations for CareScan as well. Without Rachel's team, I have to say, none of this would be possible in terms of having our evaluation done. So thank you, Rachel, and your amazing team. First, I want to start with land acknowledgement. I am in Vanderhoof right now, so I respectfully acknowledge that I live, work, and gather on the unceded traditional territories of the Daca Carrier people, including Sycus First Nations, whose deep connection to this land dates back to time immemorial. Here's the presentation overview. So this is going to be about Ormond Lake, the Healing Center, and the work that was done there. We're going to be talking a bit about the program evaluation, the approach, the summary of the results, and then which will lead us to our road to TACHIC Treatment Center that is coming up. And then we'll go with questions. So first of all, Ormond Lake Healing Center. For the ones that don't know where Ormond Lake is, we are located on Notley Witten territory. It is a seasonal residential substance use recovery facility, and we run from April to October of every year. And the Addictions Recovery Program is the program that runs that. ARP, that's what we're called. We're an integrated traditional indigenous healing practices with evidence-based Western therapies. Currently, we are offering a 6-week treatment programming out at Ormond Lake, and it is open for all Indigenous folks who live in British Columbia and up in Yukon. This is funded by FNHA. And here's our quite debated map for Ormond Lake that we give to all the clients that come. So you can see the campus right there. There's the lake. Here's Highway 16 West. And yeah, you just turn here. Just kind of give you a context. Also, without our elders and volunteers and knowledge holders, again, Ormond Lake would not be happening. We've had our elders donate their cabins out there at Ormond Lake. We've had cooks right here who cooked for 2 years for free before getting paid. And that was back in 1993. And here's another picture of our elders back then. So here's a view of Ormond Lake. The center provides an off-grid healing environment. So our big emphasis is on cultural identity, land-based practices, and community connection. We do activities such as sweat lodge ceremonies, hunting and fishing, depending on the season, nature walks, berry picking, rock picking, talking circles, traditional crafts, and of course, counseling and therapeutic services that we have offered there. We also have 7 cabins. So keep in mind, these 7 cabins have no electricity, they have no running water, and they're heated through wood stoves. We also have 2 fancy shower buildings now. And we also have 4 outhouses that is open for the use for all the clients and the staff that are there. And we have 1 washing machine that people can wash their clothes in. And then in the main cabin, which you can see back there behind Dennis and Kyle playing the guitar there, this is our main cabin here. And that's where a lot of the programming happens. There it is. And that's the view from the main cabin. Now, here's the timeline of what went down for Ormond Lake. So 1993, CSFS relocated the Addictions Recovery Program from Chislada to Ormond Lake, and that's when we began our 1-week operations back then. 2014, we started the 28-day treatment cycle. 2024, we piloted medically supervised withdrawal program. 2024, again, we started preparing the programming for TACHIC, and this year we expanded it a 6-week treatment center. We're rooted in culture, resilience, and commitment. So for 2 decades, the center provided just 1 week-long culture-grounded healing, despite all the limited infrastructure. Again, no electricity, no plumbing, wood heat, 14 kilometers in the bush, basic cabins, and just outhouses. It sounds very romantic now, but like when you're in it, it's hard. And to further show how rooted in and committed to restoring Indigenous identity and traditions by telling our elder stories. This is a really important piece of what Ormond Lake is. It's called Chuslo. So Chuslo is the mound where Ormond Lake is a sacred mound for the Noddly people. And long ago, people used to spread the ashes of their loved ones over that mound right here. And we're talking hundreds and hundreds and hundreds of years now. And the reason is people back then, that's why they're called carrier. They used to carry their the loved dead ones for a year before spreading their ashes. And these are some of our staff, hard at work. So if it's so nice over there, why are we leaving? Why are we expanding? So again, currently Ormond Lake only supports seasonal operation. We can only be there from April to October. And we all know how much residential treatment services are needed throughout the whole year. We have no plumbing. We have no electricity out there without the generator and the what do you call those? Solar panels. And we also have the big issue of the rising toxicity of drugs and the opioid crisis, that they don't know seasons, they don't know weather limitations. So again, we still need to make sure we're addressing these needs of our communities and the whole province, to be honest with you. Detox, long-term treatment, aftercare services, peer support services, mentorship program. Again, these are all very important topics that we need to address, and we can't address them all at Ormond Lake. We at the end of September, end of September, October. So it gets cold over there really quickly. Building our new center, our pride and joy. So our center right now at Tatchik Lake is being built, and it's on the Sycus First Nation territories. For the ones that are familiar with it, it's by Vanderhoof area, and where there used to be a Tatchik Lake resort on that site. So again, some of you might have spent some summers on that resort, and Kirsicania has conducted a feasibility study and went ahead and purchased the land to build the treatment center on it. So the center will have 10 medical withdrawal management beds, 36 residential substance use recovery beds. So that's in total 46 beds. We will also pilot a center of excellence for training programs. We're going to work with the universities and the colleges around us. We'll train nurses, social workers, counselors, support workers, trades, summer students from the high school. And we're going to have a year-round programming. Again, it would really expand our work to be able to provide it all year round. So here's the construction as of last year, like September last year, I'm pretty sure. And here is the concept from the engineers. As you can see here, this is going to be the detox building, admin building, therapy building, these two long, like a peace sign fingers. That's the residence that's going to have the 36 beds and kitchen and dining hall over here, shop, massive greenhouse right there. And throughout the territory here, we're going to have our sweat lodges and our smoke houses. And you can see here Tatchik Lake. And here's where Rachel's team came in, the evaluation purpose. So we want it to be based in research, based in evidence. So the evaluation helped us inform the program planning of what we want to put into our treatment center. And it also ensured that we stay rooted in culture and we stay mindful about that. The trial elements of the expanded, and we have new programming that we were able to transition into Ormond Lake and edit it out for later on when we're out at Tatchik. So this was, again, it's a multi-year approach evaluation, and it happened as we're practicing at the same time. We have season 1, 2023, 2024, and 2025. So 2023, the Rachel's team came and evaluated how our things are as status quo. So we had to have people that were 14, what do you call them, 14 days clean before entering treatment. We were out in remote location. There were no medical help, no medically trained staff, no medical withdrawal support, and the time gap between detox and entering a residential treatment center was very critical, where we lost a lot of folks due to relapse and other reasons for not being able to attend treatment on day one for 4 weeks. The next one, 2024, the evaluation showed us that we got to finally pilot our what medical withdrawal services led by Dr. Tracy Day. The nurse team came initially for 5 days, and then they had to expand it to 7 weeks, because I also think the clients that were coming out, were just starting to get used to on what is it like to detox in the bush. And some people weren't quite sure how to tell the staff, oh, I used last week, or I used 2 days ago before I came here. So information was coming in late to us about their usage, and we found out that we need our nursing staff out there longer than just 5 days. So they stayed for the whole week. Also, we found that a lot of our clients were very sick, very, very sick coming to us. Because they're medically withdrawing, some of them have not seen a doctor in years. Some of them even haven't had a good meal in months. So we've had a lot of medical primary care issues that we had to deal with, and that was a gap that was identified in 2024. Issues with mixed cohorts. We've had at the time, the first week of programming and first week of detox. So we had people detoxing, people not detoxing. People detoxing were very tired and exhausted from all the work that they have to do. And the people that weren't detoxing were quite triggered by watching their fellow clients going through detox. And now this year, the program expanded from 4 weeks to 6 weeks. So the first week, we separated the main population, the ones that don't need detox, and admitted only the folks that needed detox for the first week. So they had all the camp to themselves. And then in the last week, we had discharge planning. So the week just focused on discharge planning. We also introduced episodic care, which is temporary primary care. So our nurse Colleen came once a week, and she saw everybody, gave them prescriptions of all the things that they need, and also checked in with the staff. And we also explored some traditional detox methods with the elders there too. So next steps. In TACHIC, we are excited to start offering more intense aftercare planning and trauma-intensive program that we just launched a couple of days ago. Animal-assisted therapies. Again, we're going to be a center of excellence and training programs and staff housing. And we also, hopefully, that's the dream, community second stage housing around the area here. And least but not the least important, is the legacy of Ormond Lake. So as CSFS transitions to TACHIC Lake, the legacy of Ormond Lake has to remain foundational chapter in our story. Indigenous-led healing and recovery in Northern BC. We will not forget about Ormond Lake. This is here some of my team who, again, without them, none of this will be possible. We've learned a lot through this evaluation, and we're looking forward to the write-up of this evaluation that's coming up pretty soon. Sicho. Thank you. Is everybody still there?
Yeah, I'm like, I know that people's power is going out all over Prince George, so
Oh, really?
Oh,
Oh,
there we
go
go.
in bed, your
Where did
girlfriend. Yeah.
Vivian go?
I don't know. There's like a circle.
Do we see any? No actual
Thank
question.
Think
you,
maybe.
Sherry. I'm just reading. Thank you, Sherry.
Oh, I can
We
kind
are
of.
very excited too, Cassandra. It's going to be great.
Should we hand it over to? Oh, there we go.
Oh, what do you
Oh,
see? What do you see that I don't see?
We just hand it over to you, Jessica.
Oh,
no,
Having.
can't
that's
hear
so good to
you.
hear, Jessica. Thank you.
No, we can't
She
hear
put them
you.
through the ringer.
You want us to introduce Jessica?
We can't hear you, Vivian.
All right, we'll hand it over to you, Jessica.
Thank you. What is Zoom without like a little bit of technical difficulties,
Yeah.
honestly?
Great work, Mary.
I'm just going to share my screen. Okay, perfect. Is everyone able to see this?
Yes.
Perfect, thank you. Okay, so my name is Jessica Telzen. I'm a second-year medical student at the Northern Medical Program in Prince George, BC. I also hold a position as a mental health and addictions clinician based out of Fort St. John with Northern Health, so I'm very familiar with sort of mental health care up here in the north. But today I'm going to be presenting my master's research that was completed at Stanford University in California. So I'm going to be chatting about that and sort of its application to Canada. Okay, so obviously we all know here today that the opioid epidemic is an enormous public health burden. In 2020, approximately 2.7 million Americans had a fatal opioid use dis or sorry, 2.7 million Americans had an opioid use disorder, and over that 12 months, nearly 70,000 fatal overdose-related overdoses occurred. Interestingly, researchers found that about 70% of the national non-intentional drug overdose deaths that occurred in 2020 had at least one potential opportunity for intervention, such as medication or a reverse of an overdose, suggesting that programs can be designed to intervene and to save lives. So in the States and in Canada, there's three main categories of medications that are available for opioid use disorder. The first one being methadone, buprenorphine, and naltrexone. All of them have their own different pros and cons and what they're used for. But interestingly, in the States, specifically in California, buprenorphine and naltrexone are the only two that are allowed to be prescribed by primary care providers. So that would be like family doctors, nurse practitioners, that sort of thing. And methadone has to be prescribed in a certified opioid treatment program, which makes it quite challenging to access in the States. So in California, the gold standard best practice is to prescribe buprenorphine and psychosocial support. But despite the benefits of medications for opioid use disorder or MOUDs, patient access remains limited, with approximately only 22% of people diagnosed with an opioid use disorder actually receiving medication-based treatment. So that's a really big challenge. As well, rural Americans and rural Canadians as well face significant disparities in accessing opioid use disorder treatment, with more than half of all rural counties in the States completely lacking one MOUD prescriber. So that's quite a big area of the United States. There's a lot of different barriers to opioid use disorder, so I'm not going to go over all of them, but there are quite a few. So, for example, for the consumer in the United States especially, lots of people have challenges accessing the medication. So that's like one, finding a prescriber, but then also being able to afford the medication. So in the States, unlike in Canada, the medication is not covered. So that can be really challenging. And then you have to find an insurance that's willing to pay for it. And it's just really hard. And then there's barriers for the prescriber as well. So, like in the Canadian medical system, there's limited MOUD prescriber mentorship, which makes it challenging for prescribers to learn how to prescribe medications for opioid use disorder. There's also a lot of different attitudes and stigma that negatively impact someone's willingness to prescribe MOUDs. And as well, for organizational, there's a ton of different barriers, all similar to those in Canada, But in the United States, there's a lot of inadequate reimbursement rates as well as insurance-based restrictions. So, for example, buprenorphine is the only medication that's covered on the California formulary, which basically means it's the only medication that they will pay for if you have like Medicaid or Medicare, which is like the state provided options. But even private insurance options and Medicaid and Medicare will only cover certain like formulations of the drug. Like they won't cover every single variation of it. So it makes a significant burden on the organization and on the prescriber to know what insurance will actually pay for and what they won't. As well, rural clinics, just like we all know here in Canada, have unique barriers to providing MOUD services. So I grew up in northern BC, and when I went to California, I really thought it was going to be like super urban and very like Disneyland-like. But when I got there, I realized that basically every county in California, except the San Francisco Bay Area, has rural populations. So I'm not sure if you can see my cursor, but this little blue dot right here is the San Francisco Bay Area. Down here is Los Angeles, and down here is San Diego. So once you're outside of those major areas, basically every single county has a rural population. And like Canada, these clinics have difficulty recruiting and retaining providers who are willing to provide the medication. Rural providers have reported feeling isolated and left out of urban-focused training sessions, and rural providers have reported feeling unprepared to provide MOUD services due to a lack of specialists and behavioral health expert support. So that's all very similar to what providers in Canada experience. But despite these barriers, rural primary care providers are well suited to provide MOUD services. So there's been some research that's been conducted that has shown that rural Medicaid patients diagnosed with opioid use disorder have an average of 4 annual appointments with their primary care providers, which show that PCPs are well positioned to provide MOUD care due to their frequent patient interaction. So this essentially means that these lower income individuals who are on Medicaid see their doctors on a regular interval, which makes them well positioned to provide this care. As well, rural primary care providers who do offer MOUD services often prescribe at higher rates than urban providers. So this means that rural providers who overcome barriers to prescribing tend to prescribe at higher rates, which is quite interesting. So this sort of leads to the question of how do you enhance primary care providers' capability for MOUD provision? And that's where implementation support science comes in. So research has shown that provider attitudes and self-efficacy influence engagement with evidence-based practice. So the gold standard evidence-based practice, as I've discussed, is some sort of medication with psychosocial support, and that patients who receive opioid use disorder treatment with medication reduce their mortality by approximately 50%, which is a really big decrease. However, lots of people don't access this treatment, which has already sort of been discussed. So this initiative sort of aims to increase access in California's primary care settings. But there's been a lot of different literature that's been conducted to sort of assess how is the best way to do that. And implementation support science has had mixed results on whether methods like coaching or webinars can enhance provider capability. So as part of my master's project, I did a retrospective analysis of a statewide implementation support program. So the program was called Addiction Treatment Starts Here. And it was a multi-wave implementation support program that assists urban and rural primary care clinics in providing medications for opioid use disorder. And there was a variety of support including webinars, enhanced monitoring and feedback, coaching, learning collaboratives, and site visits. And clinics can receive up to $50,000 based on meeting benchmarks with clear instructions that the funding compensates for research data provision and not for implementation support. So if the clinic did not necessarily participate in every single aspect of the program, but they still provided their data, they still received their full funding as promised. So I hypothesized as part of my master's, I had 2 aims. So the first one was there's very limited evidence in the research against whether different organizational factors such as clinic size, rurality, or medically underserved status were the same thing or different when assessing clinics. And I wanted to assess if there was a relationship between these variables and change in MOUD capability over time. And then my second aim was to determine if there's differences between rural and urban clinics in their change in MOUD capacity. So I had hypothesized that rural primary care clinics would have lower MOUD capability than urban clinics at both baseline and follow-up, but would exhibit a similar magnitude of change. So essentially, I had hypothesized that rural clinics would be worse off initially, but would still improve at a similar rate as urban clinics. So to quantify capability, I use the Integrating Medications for Addiction Treatment Scale, which is a previously created scale, which is self-report assessment designed to evaluate a clinic's capacity and quality in delivering MOUD services. There's a bunch of different benchmark items, and just to keep it really high level, there's essentially 7 dimensions. So that's like infrastructure, clinic culture, environment, workforce, etc. Scores range from 1 being not integrated to 5 being fully integrated. And past research has indicated that IMAT is a reliable tool with good internal consistency and validity. And for my statistical analysis, I did a bunch of different things, but to keep it just really high level, for my first aim, to determine if rurality, clinic size, and medically underserved status were the same thing or not, and whether those had an impact on change in MOUD capability, I did a correlation matrix. And so this assessed the direction and strength of the relationship among these variables. And then for my second aim, as in whether urban or rural clinics had differences in capability, I did independent sample t-tests, which were conducted to evaluate changes in baseline from follow-up, which I chose because it was most suitable for my small sample sizes, as we'll discuss. So this is sort of our results. So on the left, you can see sort of the flow chart of the number of applicants, our cohort size, how many people withdrew. Based on those withdrawal numbers, we invited some people off the wait list. And ultimately, at the end, we had 77 data reporting clinics across all the waves. And then those were the interventions that they received that I've discussed earlier. And then the map is the location of, based on their postal code, of all the clinics that partook in our intervention, the ones in purple being the rural clinics. So for our results, for the first aim, I found that the 3 organizational characteristics, rurality, clinic size, and medically underserved status, I found that there are distinct constructs, which is really important to ensure that I wasn't essentially measuring the same thing 3 different times. I also found that rurality negatively correlates with MOUD capability. And I found a couple medium negative correlations with rurality, which includes your IMAT total score change and staff training. And then I found small negative correlations with rurality with patient identification, care coordination, and workforce. And those are just different dimensions of the IMAT, indicating that rural clinics showed less MOUD capability change over time. For my second aim, assessing differences between rural and urban clinics in their change in capability over baseline. As you can see in this graph, the red right here is the rural clinics and the blue is the urban. So I had hypothesized that initially that the rural clinics would be worse off at baseline and at follow-up, but we actually found that rural clinics were more capable of providing MOUD services at baseline. And both urban and primary care clinics, as you can see here, reached very similar levels of capability at the end of the intervention. However, rural clinics showed less change in magnitude of change over time. And then in this table on the right over here, you can sort of just see the breakdown of the clinics. So an FHQC is a federally health qualified center. So that's essentially like a safety net clinic, but they specifically see patients who are on Medicaid and Medicare. So they bill directly to the government versus private insurance. And then we had a couple clinics that were medically underserved versus adequately underserved. And that just has to do with the patient population they see and the workforce available in that area, and then the clinic size. And so there's a couple different limitations to this work. So the first one being that in implementation science broadly, it's really challenging to hit appropriate statistical power because especially in this study, for example, I used each clinic as its own unit of measurements instead of like the physicians or the providers who engaged in the study. So overall, we ended up using 75 clinics in the data analysis. We ended up withdrawing 2 who didn't provide both pre and post data, which made it challenging. You can't do a t-test with no pre or no post. But of the 75 clinics, only 10 were rural, which ultimately limit the conclusions that can be drawn in the rural versus urban implementation effects. As well, each wave of clinics received variable implementation support, meaning that clinics could have participated in different amounts of didactic webinars and learning collaboratives. As I mentioned earlier, clinics could participate in as much or as little as they want, which make it challenging to assess intensity and whether the intensity of the implementation changes the outcomes. But ultimately, while underpowered, this exploratory analysis does act as a first step towards understanding the unique needs of rural primary care clinics that offer MOUD services. And for a few implications of this work is essentially that more research is needed to understand rural primary care capability building programs, but our findings suggest that rural primary care providers have a stronger baseline capability than researchers realize, indicating that interventions should leverage this strength. And ultimately, that the Addiction Treatment Start Here implementation program effectively improves MLUD capability, particularly in the urban setting. So I would just like to thank the funding sponsors who are a part of this important work. So this work was generously sponsored by SAMHSA, Cedars-Sinai, Center for Care Innovation, Center for Dissemination and Implementation at Stanford University. And I'd just like to thank my supervisor, Dr. Heather Gotham, who supervised this work. Does anybody have any questions?
I just wanted to say that it was really cool to see the entire journey of your project and the way that the data came across and the interesting findings of it. And really appreciate you sharing that with us.
Thank you, Cassandra.
All right, I'm not seeing any questions. Oh, poor Vivian. All right, are we good to sign off? This was a lovely session. All right. Bye, everybody. Wish we could be in person.
Thank you.
Hopefully one day soon. Bye.
Bye.